Before we get started, we have question and answer box in the bottom right-hand corner. So if you have any questions, please go ahead and type them there, and we will address them as we're able to fit them in. We also have the chat feature right above that, so if you'd like to make a comment, please feel free to use that. And above that, on the right-hand side, is where we have the handouts for the slides that we're going to go over today. So with that being said, I would like to welcome Barb, and she'll take it away. A little bit about yourself.
Okay. Good morning, everyone.
This is capturing your sound.
Okay. Thank you for inviting me. Thank you, Donna. I have been with hospice work since 1985. I'm a registered nurse by background. I came to Salem area, to Willamette Valley Hospice in 2013. Prior to that, I was with Health Dynamics in the Legacy Hospice System up in the Portland area, McMinnville and Portland area for some 27 years. So well immersed into the hospice arena. I want to take an opportunity to thank you all for what you do as volunteers. Our organization, all hospices are required, if they're Medicare certified, to utilize volunteers, and we need to have at least 5% of our patient care hours participation with volunteers. And so we cannot function without our volunteers, and incredibly valued. So I want to thank you for your participation in helping our community and our Medicare folks and Medicaid folks and all those folks out there understand and help them through the processes. As you all know, these processes and the government regulations are sometimes overwhelming and confusing and tedious. So hopefully I can share a little bit of history and respond to your questions, or if you have certain situations that you've had that you didn't know how to exactly guide, or some things that came up that want to ask about, certainly please feel free to do that. I will start out by saying I have a lot of information. I don't want to overwhelm you with a lot, and a lot of this is very dry material, but I'm hoping it'll be informative for you. If I start talking too fast, let me know. I have a tendency to have the gift of gab, and I'm told I talk very fast. The further east you have grown up, the faster you talk. I'm originally from the Midwest, from Milwaukee, Wisconsin, and so I haven't lost my my speed along the way. So just say hey, or can you repeat that, or whatever as we go forward. Also, some of the concepts and some of the information might seem like it's contradictory or confusing. It's not intended to be. It's just, if you've been working in our system, and I'm not trying to downplay our system, but the regulatory folks back in Washington, D.C. and across the nation, there are sometimes federal regulations that cross over or are in direct opposition to state regulations. They're trying to get all on the same page, but sometimes there's a little bit of a juggling act of how to interpret the regulation. So I hope that I can do some of that for you. As we go through this morning, I'll give an overview, a little bit of the history of hospice care, how it came to be in our nation, and some of the regulations. We'll get into some of the Part D aspects as far as pharmacy benefits, and where the challenges and where the some of the confusion comes in as far as insurances and supplemental insurances, and how that all works as we go forward. I'll give a little bit of an overview of the history, and just with the different changes that happen along the way that make our world just a little crazy. And literally things in our world can change literally every 2 to 3 months. Nothing seems to stay the same, and sometimes we will go in a circle and go right back to where we started from a couple of years ago. And so even for our staff who are providing the services, we'll take information back and something will turn, and they'll say, well, we used to do that. It's like, yep, we're doing it again, or we have to change, and then they get confused too if they've been working in the industry for some time. So it's a constant learning and a constant education as we go forward. History, some of you may or may not know the history of hospice started. Hospice started as a concept of care back in England. Dame Cicely Saunders was the first person that worked at St. Christopher's Hospice. And one of the biggest misnomers that people think about with hospice care is they think it is a building, it is a place. The original hospices were, the word hospice comes from hostels, which are places of shelter. And back at St. Christopher's, it was actually a building. It was a lot of old churches and places were used to take in those who were dying who did not have caregivers to take care of them. And way back in Mother Teresa days and in Dame Cicely Saunders' time period, she wanted to make sure that, number one, no one died alone, and they were provided as much comfort with dignity as possible. And to this day that stands. The movement of the hospice care has turned into a concept of care and is now worldwide. It is predominantly in the United States, concept of care where hospice services it's a delivery model of care where services are provided wherever the patient calls home. There are some inpatient hospices or buildings that are certain types of facilities for hospice patients, but the majority of hospice care across the nation is provided in the patient's own home. The patient's own home can be wherever they're residing. It can be in their own home, their own place of residence. It can be in a family member's home. It can be in a assisted living. It could be in an adult foster care home. It can be in a skilled or in an intermediate care facility. At times, it can be in a skilled nursing facility, if you're familiar with those terms, but there has to be, there's some regulations that go around with that. Some of our patients, as I said, wherever they call home, we have served people under the bridges. We've served people that have been down in the shelters. We have served people in the backs of their cars. So if we can find them and they agree to having a relative, and I'm putting that in air quotes here, a relatively safe place where we can provide care, we will try to provide hospice services for them. The primary goal is to, as I said, provide comfort and dignity. And the other piece that some people get kind of turned around when people hear hospice, the word hospice is, and that's a little bit later on in the presentation, but they hear hospice and they think it's an immediate death sentence. Hospice, the services of hospice care are to come in and help someone, assist them when they have a life-threatening or a terminal illness that they may die from within 6 months or less. And that is if it's predicted to happen within a 6-month time period or less. To the best prognostication, to the best that the physicians can tell, it's if the disease takes its natural course. There are many folks that come on with hospice care and live well beyond 6 months. As a matter of fact, many folks that come on very late in the program, so they are on for a very short time period, even weeks. But there are several people that if they have a life-limiting illness and they're still declining, they have been served for sometimes 1.5 years or 2 years or longer. The Medicare benefit in the United States really became solidified in 1983. There were a lot of people across the nation kind of doing the shakers and doers that started hospice care in the late 70s and it carried into the 80s. And those folks, the majority of hospice care in the United States were started by service organizations, usually churches or people that just had a passion to provide care for people at the end of life. By 1983, the presence of those folks in providing comfort and symptom management, or trying to guide people in their symptom management for care, became known across the nation, and Medicare actually developed a benefit. And as many of you already know, Medicare has several different, what I refer to as pots of money. There's the traditional Medicare A benefit that is primarily a major medical benefit. There's Medicare B that supplements more care in certain types of services. Medicare D is the pharmacy program. There's the black lung program. There is the end-stage kidney disease. And then there's also a hospice Medicare benefit. So in general, what came out in 1983 is that patients, people who have Medicare A are entitled to choose to elect the Medicare hospice benefit in lieu of their Part A benefit for a condition related that is a terminal condition or a life-limiting condition. That gets a little bit confusing sometimes when people have multiple types of conditions, and I'll go into that in a little bit, but there was a hospice benefit started specifically for terminally ill patients in '83. By 1989, in order to call yourself a hospice, you needed to become Medicare or Medicaid certified. In 1997, things went along the way from the late 80s into the 90s, and in 1997, the Balanced Budget Act came out. And that's where there was a lot of scrutiny, and the OIG, the Office of Inspector General, came and started looking at some practices, and they really started vetting through how programs were applying the services, and then also looking very deeply about if the benefit was being distributed and provided consistently from hospice to hospice. And at that point in time is when we found there was a little bit of variation from program to program and across the nation, that services of hospice care were not necessarily being provided consistently from beneficiary to beneficiary, or from program to program, or from geographic areas across the nation. So great scrutiny came, and the regulations became very, the interpretive guidelines became very specific and very literal, and it made our world go topsy-turvy. At that point in time, between 1997 and 2002, many hospices closed. After they had survey, they were found to not be doing things timely or within the regulations to the literal extent. And so a lot of different organizations and home care agencies and hospice agencies had to really change up their practices, and so they were meeting the standards, and not just meeting the federal standards, but meeting their own state regulations as well. So for the most part, the basic overarching hospice services has not really changed from 1983, but they did get reinterpreted in 97, and they were just slightly revised in 2008. And so for hospices across the nation right now, the conditions of participation for hospice care and services, and the way you must manage a hospice and provide hospice services on the interior as far as staff, as well as the services provided to the community, were revised somewhat, but they're still basically the same that they were even back from 1983. That has pros and cons to it because, of course, we're now in 2018, and 1983 was a long time ago. And there's a lot of different changes, our environment and how we perform things, technology, how we have managed things along the way. So the hospices have been met with a variety of significant challenges in order to be able to meet the regs in the way that it was described back in 1983, and still applying today's technology, the services, the healthcare systems, the corporate structures, and now with a lot of the different health providers grouping, the coordinated care organizations, and how we all work together and integrate our care together and work in partnership. So part of that is wonderful and awesome because we can still provide hospice care. And my passion of staying in is I have found an affinity to serve folks who are in the time period of their life where they are having more of a predictor that they may die in a shorter time period. The joke that we have, it's not a joke, but we all know we're dying. From the time we're born, we know that at some point, for the most part, we think we're mortal and are going to die. So for hospice folks, in theory, there is a perception that they have more of a life-limiting or a time frame associated. So when hospice comes in, a lot of people think that we're coming in and they're going to die automatically within a couple of days, which sometimes can happen. But more so, they think it's a death sentence or that we're coming in to euthanize them. And that is something that is absolutely not what we do. Hospice care is really for services supportive and identified and specifically identified to the patient, that particular person and their family or their caregivers and who's ever in their environment as a unit of care to assess and find out what their particular needs are for their particular disease, for their particular situation, and for a variety of us to see what we can do to help that person to live the best that they can until the time that they die with the best quality of life, but within their choosing. And that choosing of quality of life is very different from person to person. There are some people who want to try to stay alive for certain an event, a birth coming up, a wedding, a graduation. This time of year we have several folks who are really committed to trying to stay alive for their grandchild or their great-grandchild's graduation or their own child's graduation, birthdays, things like that, memorable type things, or weddings. Other people, they hear that they have a life-threatening illness or a terminal condition and they're done. They do not want to live. A lot of folks can't see themselves going from here to, they can see themselves from here to death, but they can't see themselves in the middle, having that decline, having the burden of symptoms, and potentially losing their dignity and their independence. So those are some of the things that a hospice service can come in and help with. So the focus, as I said, comfort, dignity, and symptom management are what we focus on for the most part. Most often, people that have life-threatening or terminal illnesses have symptoms that are showing the decline when the body systems are failing. Oftentimes, the priority symptom that we have, that we work with folks is trying to manage their pain and trying to get their pain under control. Nausea and vomiting, anxiety, functional decline where they're not able to be mobile anymore, a variety of different things coming up depending upon what body part is affected and what might be broken, so to speak. So that is a big part that the nurse participates in. The other piece for hospice services, when someone is referred to hospice care, and their doctors, for the most part, and even the families may have come to the conclusion where there are not a lot of treatment options available, or things have been exhausted, or they're just futile. The other piece is talking to the patient about what their goals are. The goals of hospice care are really significant, and we have to do a really good job of talking to folks about what they really want to have for themselves. The more we support the patient and their family being in control of what happens to them. We don't come in as a vigilante group and demand that they do things. There's certain regulations that we need to meet, but within lawful entities and within safety standards, it's the patient's choice. So if a patient, even if they have a life-threatening illness and may die, if they choose that they still want to go to the hospital, they want to have aggressive care, they want to participate in treatment options that are out there, they are supported in doing that. For some of those folks, the Medicare hospice benefit is not necessarily the best program for them. It's in some ways because we're at conflict with the philosophy. If we don't treat symptoms and if someone wants to have curative cares and curative treatments, it doesn't help to not help that person help themselves, and then all of a sudden when they're in dire straits, have them try to have a treatment option or something that should have been helped along the way. So we talk to people about that. There are some folks that are indecisive, so we go day by day and time period by time period based on what symptom comes up. But for the most part, people that are going to have hospice care or palliative services is that they are not seeking necessarily aggressive treatment for curative care. They really do have an understanding for the most part that this illness or this condition or these multiple conditions are going to take them down a pathway where their life will end. It doesn't mean we won't do aggressive symptom management and help them stay as comfortable and as symptom-free as they can, but there is a lot of conversation, and each time that those come up, it requires a new conversation at a different point in time.
I have a question. So if someone has been diagnosed with a terminal condition and they have less than 6 months to live, but they decide prematurely that they're done with it, but their body hasn't decided to shut down, does hospice support or aid at all with organs death with dignity?
So different hospices across the nation, I can speak for our hospice. When the Death with Dignity Act became, it was in legislation for years, and then the bill got passed and it got overturned, and then it came back in again. During that time period, the hospices across the nation had much conversation and ethical and moral conversations and decisions about how we would support or not, and it was extremely controversial across the nation and then individually, locally. Most of the hospices today will support a patient that is going to be that chooses death with dignity. We follow the act. So for the hospices we can provide information. If someone is interested in pursuing or how it works, we provide literature. They can contact them. We can help get them in touch with them, but we don't advise. We take a neutral stance. We support the patient's right for self-determination, and if that is their choosing, we support them and get them to the education and information that they need, but we don't participate. Our nurses, when patients, there's a couple of week process where they need to be seen by 2 physicians who deem them terminally ill and then also mentally having mental capacity to make the decision themselves. Someone else cannot choose for someone else that they're going to do death with dignity. Death with dignity medications are taken and have to be self-administered by that patient themselves. If someone now has a neurological disease, they can be assisted in taking them if they have capacity, but for the most part, we cannot pick up the medications, we cannot order the medications, you cannot facilitate, our practitioners cannot facilitate any of that. But we can be present to continue to support the hospice care as far as their symptoms, their education, the emotional support, the family, the bereavement, the whole 9 yards.
Wonderful.
If a patient, when a few years ago when the act was new, we had a lot of patients, there weren't that many patients. That's another whole piece, which is a whole other discussion, but of the people that choose to participate in Death with Dignity, many of them will go through the process or want information on the process. Sometimes they don't even get the medication, but they just want to know it's available. Other people get the medication and have it and tuck it in a drawer, but they don't use it, and other people choose to use it. So the common theme that we see is most of those folks are people who are highly educated, that really have been quite independent and don't want to be a burden to their family. That's a common of the data that has been drawn. So again, it's coming back to that patient and having them stay in control. And what I was going to say earlier is that when those folks first came on, a lot of people wouldn't tell us, and then all of a sudden they'd not be here, and things were kind of done underground. Well, now that it has been more talked about and informed and educative, and people can be supported during that time period, people usually tell us. We actually put it into we have to create plans of care that are very specific for our patients. We actually add it in so that we know that it's present. The way that we might offer bereavement support or medical social work support, psychological, end-of-life care, finalizing business factors at the end of life might make a difference if we really do know and somebody is planning on using death with dignity on a particular date or a particular time. It changes our framework of how we support and work with folks. So not all hospices allow their staff to participate. Most hospices, and when I say participate, meaning going to the home at the time that the patient may be taking the medication. Our particular hospice and my prior hospice, we did allow staff to go. Our philosophy is, again, they cannot participate in any part of the act, but supporting the dying process, taking care of post-mortem care, things like that, supporting the patient and family, and just being there. And we don't automatically go. It's that patient's choice to invite our staff. And oftentimes they have developed a rapport relationship with their primary nurse, case manager, or their social worker or spiritual care provider, and to have that support there. So oftentimes we're invited. Our own staff can choose if they are willing to participate or not. We have people on all ends of the spectrum, from one side to the other. Some people that they do not feel comfortable participating and going. On those folks, they can opt out of providing care for those patients, and we have other folks that feel comfortable that can maintain a neutrality and support the patient with their wishes.
That's really great information. Yeah. Thank you.
Okay. So part of going forward, so goals of care, I have to, of course, add in fun stuff. These are my grandkids. One of the things that I can personally attest to is I was diagnosed with, breast cancer back when I was 41. And at the time, it was a stage 3, stage 4 breast cancer. And they started talking about very extensive treatments right off the get-go. I was not given a very long time to live. And I am now, some 20 years later, still alive and very well. And at the time, what was important to me, I talked to a variety of people, and what kept coming back to me, or what was very evident for me at that time period in my life, was that I bargained. You hear about those the old Kubler-Ross's stages of grief, of anger and bargaining, acceptance, and different things. So my bargaining was I wanted to live at least 5 years so that my children were just a little bit older, to be safe. I was not in a very good marriage at the time. I was really worried about my children. My children were 9 and 13 at that time, and I thought at least if I could buy 5 years, that they could be a little bit better taken care of and be able to be a little bit more informed in the world and choosing and different things. Well, lo and behold, 20 years later, I'm here, and these are my grandkids from those kids. So talking about goals with patients and families really helps to drive what helps us assist them in their interpretation of what quality of life is for each individual. And it's very individualized. The other things along the way are having those goals and motivations for people in life are one of the, as I said earlier, hospice care, when we first get involved, people don't even want to say the word hospice. They're afraid to say the word hospice. They don't want us to use the word hospice because it means death, and it's equating with death. Well, death is a part of life, and as we provide care, one of the things that we still want to focus on and we bring up is that of hope. And we really find that there's a difference between having symptoms of pain and suffering, and that suffering is very different than pain and other symptoms, and that suffering can be described how it's unique for everyone, but that suffering is oftentimes connected with a lack of hope. And hope can be defined in a variety of different ways, whether that is goals to stay, to try to be alive for one of those events. But hope is also hope to have closure with family members, hope to have getting some finalized business in place. You all know we have elderly spouses who, one spouse has never written a check in their life. They don't know their finances. They don't know how to do anything. The fear that comes with losing their partner, just not only due to the sadness and the loss, or the sadness due to the loss, but how to function in life, their security, their livelihood, their safety, their intimacy. And so some of those things we tie into, which is what drives, where I'm getting to with this, is the whole interdisciplinary team for hospice services. It's not just a medical program. And that's one of the hardest challenges that we have with the regulations that came out from Medicare, because the Medicare hospice benefit is a medically driven program. And the program of hospice services is holistic. It does have every patient that has hospice care automatically has an RN case manager assigned to them. They have a medical social worker, a spiritual counselor, and a hospice physician in addition to their attending physician. There are other folks that are involved in the interdisciplinary group. They can be licensed practical nurses. We have hospice aides to provide assistance with personal care. We have volunteers to do a variety of different things, and I'll go into more things later on. We have occupational, physical therapy, and speech therapists that we contract with. Some hospices have their own staff that provide this care. The core services must be employed by a hospice, but some of the ancillary services can be contracted out. Having occupational, physical therapy, speech therapy, with the focus of maximizing function and supporting people with their changes of their functional decline. We have bereavement counselors. Our particular hospice, Willamette Valley Hospice here in Salem and the surrounding areas, we do have licensed music therapists, licensed massage therapists, and of course the interdisciplinary group is the patient family caregivers and their attending physician. Hospice services, the nursing services, and the nurses and the physicians and the hospice aides probably have the most association with the true medical components of hospice care. They're primarily working with the function, with the physicalness of someone, the physiology of why their systems, why their body is changing with their diagnoses and the different types of diseases that they may have. But the counseling services, emotional, psychological, spiritual, nutritional, bereavement counseling, clinical music, massage therapy, volunteer services, and some others are working with the patient with their psychosocial, their livelihood, their walks of life, what they've done in the past for their living, their integration with their family, what their current situations are, past is. We serve many veterans. There's a nationwide We Honor Veterans program that has certain criteria of supporting veterans, where we honor veterans and have veteran ceremonies, and then also gear the counseling to some of the veterans that may have been in combat. And again, based on where their comfort level is in delving into those types of things. Some are very closed, some are very open, but PTSD for significantly with our Vietnam vets is really significant in our 50s, 60s, and 70-year-old population right now, which really affects things at end of life. So tying into a variety of factors that people care about in their life really helps the hospice providers help identify and help the patient and the family identify needs for themselves, what might be of help to them. We do have pet therapy that can go, the certified pet therapy animals through our volunteer program. Willamette Valley also has in several other programs too. It's called Pet Peace of Mind, which is a different program that was started by the Banfield organization with a hospice chaplain who was also a veterinarian a few years ago. And they established a program where hospices can actually support patients and their families' pets of the folks that are dying, where they can help get them rehomed. They can help take care of them if that person is debilitated to the point of not being able to take care of their pet while they're alive. Volunteers can go in and pick up and do a variety of different things, walk the pets and feed them and do different things. So there's just, wherever that patient is needing some assistance, we're trying to have various different opportunities to come together to integrate their care or their services that are available to assist with them. This is my mom and my dad. And again, kind of going through both, I put this in here to remind me too, both my folks. So hospice care, when it first started in the late 70s, early 80s, in order to be defined as having a life-threatening or terminal diagnosis, and to die within that 6-month time frame, it was looked at very literally that you had to die within 6 months. And that was very difficult, and it was difficult for the physicians to prognosticate when a person was actually dying. But what was a little bit easier, if someone had a cancer diagnosis, they were a little bit more predictable, because cancer diagnoses more or less have more of a predictable trajectory, downhill trajectory, so they could put time frames on things. Along the way, a set of guidelines was developed that opened up hospice services to not just cancer patients, but also to people with heart conditions, lung conditions, liver disease conditions. When they saw the benefit of what hospice services could do for cancer patients, more and more people started getting referred if the physician felt that they were on a downhill path, maybe having had several heart attacks, maybe having a lot of asthma, emphysema, where they were really not becoming functional anymore and were having a more predictable course. Along the way, patients with Lou Gehrig's disease or ALS, the different types of sclerosis diseases, debilitating functional diseases that you could start to predict when someone was having significant breathing difficulties, or where their intake of food was such that we really could tell that they were going to die in a shorter time frame versus longer time frame. The regulations got a little bit more loosened up a little bit, and there were some guidelines that were called local, I'm getting a little bit ahead of myself, local coverage determinations, and I'll get into that in a minute here. But the point of putting my folks up on the slide, my dad was diagnosed with prostate cancer. He chose not to have surgery. He had radiation seeding instead. A couple years later, he got 2 different kinds of bladder cancer. He made it through prostate cancer. He made it through 2 different types of bladder cancer. He was not ill in any other way. My mom, when he was going through bladder cancer, ended up having a kitchen fire, of all things, over some chicken soup, and she had been a smoker in her life, but her lungs literally got fried, and she became immediately on oxygen and was literally 5 years before she died, not able to get out of her home, literally sat at the kitchen table, could barely get to the bathroom. But from her condition and my dad's condition, they didn't die from those conditions that you would normally think would take your life in short order. At the same time, when my mom's condition did decline, where she got to the point where I could predict that she was going to die, and things were changing, and she was having weight loss, and she was having several different symptoms and things come up where it was predictable. I, even being in the field where I was, and this is in 2008, so this is 10 years ago, but nearly 20 years as a hospice nurse, I could not convince her physician to order hospice care for my mom. And she died in a care facility with the nurses taking care of her. But what we had a loss about that is that the doctor felt, because she had a long-term lung condition, that she wasn't predictable enough that he could predict exactly when she was going to die, which is not what we're asking the physicians to do. You have to look at different prognosticators and some different trends and patterns. So my mom, and so what I find was the loss with that, my dad lost out on the bereavement services and on the support. I was out here in Oregon, they are back in Wisconsin. I was 2,000 miles away. I have one sibling that was not really able to help them to the extent that they needed help. And so when my mom died, it was my dad who really lost the support and tried to get him into a group. And by that time, and we knew they were married for 64 years and died just shortly before their anniversary. My dad actually died 18 months later, and I don't think he died of his prostate cancer or he truly died of a broken heart. He had started to change. He started to lose weight. He did have a residual issue with his kidneys, with his urinary function. So about 6 months before he died, I brought him out to Oregon, and he lived in my home. And as he was declining and not taking in food and not really participating, he could no longer walk to the car. We couldn't go on things. Again, I had a hard time getting his physician, who was a palliative care physician, to order hospice care again. And I thought, okay. So I basically went and I wrote out what we need to have in order, I knew the different things that they would be looking for. And lo and behold, they did agree to have him come on, and my dad died within 3 months. He died almost 3 months to the day later. So even knowing the information and having a lot of what hospice practitioners and entities do is providing education and providing information about the benefits of hospice, but it's the people themselves that receive the hospice care, and it's usually their stories and their experience that they're sharing with other people about how helpful they can be. Are there time periods where it doesn't go so well? Yep. We have people, we can't meet their expectations. We can't, in the day of instant gratification and instant time, we have a service area that we have to provide. People want us to be there when something is happening within 15, 20 minutes. We may be an hour away. There's no physical way to get there. So sometimes people we can't meet their expectations, but we try to work within that. And sometimes there are some trip-ups, there's some communication issues, but for the most part, most of the patients are served well. But because it is in that interdisciplinary group of services, and we all work together to provide that support. Hospice care, as you know, is the Medicare benefit for hospice care is based on a reimbursement model that is considered a per diem, meaning for every day that a patient that is on hospice from the time of admission to the time of their death, the hospice gets reimbursed an X amount of dollars per day. In this particular area, in all the geographic areas across the nation, the dollar amount is different based on the market basket and the wage index of that current area. For instance, in Salem, the hospice is in Salem based on where the patient lives, not where the location of the hospice business office is, but location of the patient, depending upon what county you're in and what zip code you're in, gets a different payment. There's a different payment for people that are more rural and in Salem than there is in Portland. The cost of living is higher than Portland than it is here. Portland gets a little bit higher reimbursed. The theory is that, and it's only a couple of dollars, but it does make a difference over time. The theory is people that are in the Portland area, their staff in the different facilities and the different contract agencies are a little bit higher priced in that area, so it adjusts that way. But basically, it's about $170 a day that the hospice gets reimbursed currently. When I first started doing hospice care, we were at $73 a day back in 1983. So $170 a day to some people sounds like a lot. You add that up, it's several $1,000s a month. However, one of the things that with the hospice services, the hospice is required to procure, meaning to obtain and provide or under contract, all of the services that are related to hospice care and that are related to that patient's terminal or life-threatening conditions. So that means all of the nursing services, all of the medical social work, all of those services that were on that other page, they're all provided to that patient, and it's individualized based on what the needs are of that family. All of their medications, so if they are on a variety of pain medications, any type of medications that they are intended to have to help their symptom management and help for their comfort, for the most part, have to be paid for by hospice. And I'll get into the Part D benefit later on, where it's gotten quite challenging at times. But the services, the medications, the equipment, if a patient needs a hospital bed, oxygen, DME, wheelchairs, walkers, those types of things. And then any of their biologicals, if they have wounds, wound supplies, medical supplies, incontinent care supplies, personal care needs, all of that needs to be reimbursed or paid for and provided by the hospice. And so when you look at that $170 a day, if you start itemizing those things out, if you've ever had a recent hospital bill, you can see how costly things can become. And in one medication alone can wipe out a day's reimbursement for care. So what has happened with the hospices, they've almost had to become like a managed care organization, where the hospices have to decide for themselves. And this is where there's a little bit of uniqueness comes from one hospice to one hospice based on how large or how small you are. You have to provide the core services based on your means of financial flow and personnel flow, human flow, human resources. And if you can't, then you must limit what you can do. But you still have to do the core services for those folks that you have on, as far as providing, as I said, the services, the medications, the supplies, and those types of things. One of the opportunities that has happened along the way is that the Medicare benefit is set up for Medicare recipients. We started seeing and in general, when hospice started, we saw more folks who were more elderly in the 70s and 80s. 80 to 90% of our population was 80 or older. Then it started going into the 70s and the 60s, and we found that there were persons that did not have a benefit for hospice care because they weren't Medicare eligible or Medicaid eligible. The younger folks who became Medicaid eligible, Medicaid services across the nation quickly mimicked the hospice care benefit, so that Medicare patients who are eligible for Medicare and Medicaid basically could receive the same services and get reimbursed. The reimbursement is slightly different, and again, that's based on county and state to state. Not all states have a Medicaid benefit that pays for hospice services. Here in Oregon, we do. Washington, I believe, does. Medi-Cal in California does. There's some states in the southeast section of the United States that don't have a Medicaid benefit. But for the most part, Medicaid and Medicare. And then what was lovely is that some of the insurance companies caught on, because they have had third-party insurances that saw the benefit as well. Blue Cross, Oregon Dental Association, Service ODS, MODA, those types. And so they were quick to come and start seeing the benefits. And why that was is that the government along the way, when they started doing a lot of scrutiny between for the hospices to making sure that they were doing right, they also found out that the hospices were saving the system a lot of money, because we were preventing rehospitalizations, preventing people from going back in for needless treatments, those types of things. So there was actually a benefit to Medicare hospice services that was a cost savings, and to this day that stands true. And patients have liked it because they have not, their quality of life has been better. They have not chosen to just be treated and have misery and suffering sometimes when they've treated things that were futile. So health insurance companies started seeing the benefit, and they also started developing benefits that looked like the hospice Medicare benefit and the services. And so for the most part, most third-party insurances, commercial insurances, will cover hospice services as well, but it's still independent based on the particular, if it's an employer benefit or a global or group benefit. And then a lot of the hospices also have their own foundation fund or charitable care funds. Most of those funds are supported by the community, giving funds or memorials that have been given so that no one goes without having hospice care. Along the way, a couple of years ago, In 2008, the regs actually changed to adding the regulation that a patient cannot be denied service based on inability to pay. So most hospices now will provide service regardless of that ability to pay. And in our particular area in Oregon, we are now able to serve, occasionally we have families that their family member has come from overseas. They lived in England. They have come here. Some folks that have come from other countries have come and they're living with their family and they get ill while they're here and they're not a U.S. citizen. We can still provide hospice services to those folks, and we provide charity care. Those folks that we provide charity care for still need to fill out a financial program. There's a few folks that will do self-pay for hospice care. Most don't. They usually have a benefit of some sort. And there's a few folks that have hospice care that they may have TRICARE or been a federal employee, and so their employer benefit of the classic one is the Federal Blue Cross program for federal employees and railroad employees. If those benefits will follow those employees even after they're retired, and will oftentimes be primary for their insurance, and the Medicare will become secondary. But for the most part, Medicare recipients, Medicare is their primary source.
We do have a question. So if someone is on hospice, let's say due to a cancer diagnosis, and they need to go to their primary care physician, let's say for a urinary tract infection, are they still able to go to their primary care physician for an unrelated condition?
The simple answer is yes. And they can actually, anyone that is on hospice can go to their attending physician that's on file as their attending physician for hospice care at any time that they want, regardless of what it's for. What is challenging, and so the next slide will go into what's called local coverage determinations, and this is where it gets a little bit tricky. Local coverage determinations were set up, so a little bit of regulatory history. Hospices across the nation all have a government entity. It's now called hang on, I have to think of the terms, a Medicare Advisory Committee, that or Medicare Advisory Contract, that particular entity oversees the hospice services and reviews their provision of care and gives an okay to the federal government to pay the hospice, and it ensures that they're doing hospice care the right way or providing services in the right way. Each one of those elements, we have national government services here in our particular area. They separated out into jurisdictions a few years ago, but there's one that's called Palmetto. There is national, which is now, it used to be called United Government Services, now it's National Government Services, but there's 4 or 5 of these entities that oversee the nation in different sects, and they have developed what are called local coverage determinations. The local coverage determinations are a set of guidelines, but they're used very literally into helping a physician and helping the hospice identify when a patient has certain criteria, certain signs and symptoms or ailments that will qualify as those prognosticators, the predicting that someone has more of a life-limiting illness versus a long-term chronic condition. As I said, the cancer care folks are easier because there's been a lot of research, there's a lot of trajectories, they're a little bit more predictable. Sometimes a cancer patient, though, will come to us and they've just undergone severe chemotherapy or significant chemotherapy or radiation, and their symptoms and the side effects of the chemo are so severe they look like they're dying. So they may come on, and after a few weeks, 6 to 8 weeks later, they're actually perking up quite a bit after their treatment, and they're looking pretty good. And it's like, ooh, maybe I'm not dying after all. Maybe it's starting to kick in, and they actually have gone off the benefit or go off service and can come back on if their cancer comes back or takes a turn. The ones that are more challenging are the heart disease, the lung disease, the people with dementia, Alzheimer's disease, and there's all types of dementia which is different from Alzheimer's. For instance, for Alzheimer's disease, on average, they say that Alzheimer's patients start developing Alzheimer's changes 13 to 14 years prior to death. So if you start having those changes, and even when you get into a functional category, there is a screening tool, an assessment tool that is called a FAST, and it's a functional assessment score, and it has different areas of functional loss associated with it. And the more loss you have, the higher you go on the scale. And for instance, most of the local coverage determinations for an Alzheimer's patient, a patient needs to be at a 7A. And that is, the patient can already be not eating as well, they are looking for some weight loss, they're already, could be totally incontinent of both bowel and bladder. But 7A is when it gets to the point where they are starting to not be able to say 6 intelligible words in a sentence, or their language is what we refer to commonly as word salad. They're saying a lot of words, but they're not necessarily in context or consistently making sense. From there, it goes on to the inability to smile, to the inability to hold their, I'm motioning these things that you can't see over the over the webinar, but inability to hold their trunk up or their head up, and things go down, and it can go severe from there. But a patient needs to be at least 7A on that function scale to have the first qualification for Alzheimer's disease for end stage. So those local coverage determinations have very specific things that they use that are set up for the physicians to use for scales. Heart, for instance, heart disease is one that the patient should be, there's a lot of people that can get around with oxygen and do different things, and they may be not able to do what they're able to do, but they're not dying either. So they're looking for things that are really debilitating, where there's where they're significantly short of breath, even with their oxygen on, or if they move 5 to 10 feet and need 10 minutes to recoup again. So there's different assessments that we have to look for, and we need to have all those things documented in order to show and to prove to Medicare that someone is terminally ill. So those local coverage determinations came out more specifically for the non-cancer related diagnoses. And so that's what our physicians use now to go forward.
And Barb, I just want to clarify, Hospice MAC is National Government Services in Oregon?
Ours is. The Willamette Valley Hospice is. I think everybody now in the state of Oregon is National Government Services. Yeah.
Okay, because we do it with a lot of third-party contractors like Levanta and...
Yeah. So Levanta is a quality organization, different than the MACs.
Okay.
So Levanta is it's our QIO, our quality independent.
Okay.
So if someone, so I'll get into that in a sec.
Okay, but National Government Services
Yep.
actually approves the payment.
Yes.
Okay,
Yes.
so that's like
Yep.
Noridian for
Yes.
Part B.
Exactly.
Only
Yes.
that's for the hospice portion.
Yep.
Got it.
Yep.
Got it.
Yep. And what is good about that is that having one MAC oversee all the hospices in our state, it helps us work with one another so that we're all consistent and interpreting the regulations and applying the regulations in the way that we need to, and that they're going to be looking at them and applying them the same way. In the past, years ago, Legacy, before they did this jurisdiction divvy up, Legacy had CGS, which was central government. Anyway, we were the only hospice in the state that had that one, and the only other people that had that were in North Carolina, South Carolina, and the eastern part of the state, and things can be very different geographic from one end of the country to the other, so that made it very difficult. And CGS was extremely critical and much more literal in their interpretation. So when we were doing things, and other hospices we're doing things a little bit different, people say, well, you're doing that and you don't need to be doing that, or vice versa. Mm-hmm. So now that we're all under one roof or one entity, it's making it easier for us to talk to one another and make sure that we're all in compliance and working with one another. So a couple of years ago, the other thing that happened is, and this is getting back to the UTI, and if you have a urinary diagnosis, there was further interpretation across the nation. It used to be that if you had one terminal diagnosis, that's all you needed to put on the bill, and you were focusing on that. and you didn't need to necessarily worry about other conditions. And so we thought, until the interpreters came through and said, no, even from the get-go, it should be your terminal diagnosis and all related conditions. So now that put a lot of people into a tailspin. And so our physicians now, it's everything that is related to the terminal. I'm going to step back a second. So a patient that came on a few years ago would come on with cancer, or even if they had heart failure, they would be, I'm trying to think of a good example. We always used to use the example, somebody had cancer, came on, fell, broke a hip. Their hip, you could still go to the hospital, have it pinned under Medicare A. You would go, the hospice benefit would not be billed for that. It's not part of the plan of care. Now, if somebody falls and breaks a hip, we have to go back to see if that mobility change has happened as a part of their terminal condition. And if it is, we have to help that patient and family decide if they're going to have aggressive care or just keep comfortable. We have actually ended up going in and having people pay, or people get supported to have a hip replacement, but other times not. So each one of those entities, based on the patient at a particular time, it depends upon what their related diagnoses are as well. So
that brings up a question that I get quite frequently when I'm dealing with counseling people who are either considering hospice or are on hospice, and that is, should I keep my Medicare Advantage plan or my Medigap policy? Am I able to stop paying those premiums and just rely on hospice? What are the pros and cons of going either of those directions?
Yep. And that, again, it's a really individual situation. It also depends on how sick, how many ailments that are tying into their decline that they have. There are some people where for the most part, it's a little bit of a gamble, but let's say if someone has stage 4 cancer and they have metastasis through their body systems, it is unlikely that they would need to use their Medicare supplement. It's unlikely that most of the things that they will need for their care in that terminal status will be paid for and covered under the hospice benefit, including a urinary tract infection that would come up because of their immune system.
Yes.
At the same time, and this is where it can get a little bit confusing, we do go, in the state of Oregon, we do have a PULSE form, which is a community information form where it's physician orders for life-saving treatments. That form has been modified, so we do talk about if the patient wants to be fully resuscitated, if they have a heart, if they need resuscitation, right? Yeah. We do talk about whether they want tube feeding or not, talking about if they want antibiotics or not. There are some times where, for a short time period or things are mild, where we will say, yeah, it makes sense to have a short-term oral antibiotic to get over a urinary tract infection that you're not necessarily going to die from. Mm-hmm. But if you have a condition, and some folks that have dementias and different things have repeated, a lot of, and cancer patients as well, some people don't die from their primary illness. They die from secondary infections underneath. They die from pneumonias or urinary tract infections. When they're repeatedly happening and over, and they are still debilitating, and those organisms, they're not being helped by an antibiotic, or the antibiotic is actually could cause more harm than good, because antibiotics can really affect your kidneys. And as your body systems are declining, there becomes a choice there. So it's not that nothing is excluded, but not everything is included. And it really depends upon where that patient is with their particular disease processes, how far out they are from where we think from death. If someone is what we refer to kind of upstream, if they're a few months out or so and are doing pretty good and they're mobile and they're eating and pretty functional, we'll say, yeah, it makes sense for you to have this antibiotic, and sure, we go get it and have it go through. If someone looks like they're, in bed, not functioning, hardly eating, looking like they're starting to have changes, not being very responsive, we're not going to encourage that person to have an antibiotic because it's futile. It'll either hasten their life, and or it won't really work. So the focus for hospice care is not under the underlying disease treatment that most antibiotics are for, but it's focusing on symptoms. So if somebody has an ailment of some sort, well, for instance, a fever, we won't treat fever necessarily with an antibiotic, but we will treat fever with a cold cough and Tylenol or ibuprofen or something like that. We'll treat the symptom and the effects for comfort versus the underlying disease. And why that is as the systems are broken and as the body organs start not functioning or partially functioning, most of the aggressive treatments or the curative things that we do for folks won't work because it needs the body organ to try to work for it to the best that they can. And when someone is in that dying process, it just doesn't work the same way. So it becomes futile, it becomes a waste and of money and resources, but it also can potentially cause harm. One of the other philosophies of hospice care is that we don't hasten death, nor do we prolong death. But that's a very individual, and that's a perception that comes along the way with different people and where they're at with their trajectory. But we also will support a patient who so what I was saying, depending upon where they're upstream or not. If there's a patient today that is, so today's June, let's say there's a wedding coming up in August, and they really want to try to stay away, we will support that patient with more aggressive symptom management so that they can be as well as they can with the quality of life to participate to get to that wedding. If somebody is not having that and they're like, nah, it's their choice, and we would support you in not taking that medication and doing that. So along the way, along with those, so as we have to vet out all of those, what is a related condition, what's not a related condition, and if you know anything about how our bodies work, most things are connected. It's hard to differentiate out heart disease from when you have some kidney disease. They go hand in hand oftentimes. People that have pancreatic cancer, if they have diabetes, you can't really separate out their pancreatic. The pancreas is the main organ that controls the diabetes. So people, and a long time ago, we used to say, well, you're not dying of your diabetes, but you're dying of pancreatic cancer, and we could just have pancreatic cancer as the terminal diagnosis and not the diabetes, and we wouldn't have to pay for the insulin and all the different things. Now we do. It's associated. So any of the primary and related conditions that may be contributing factors to that person's demise or to their decline, we have to cover on our service, and that has really cost you a lot. Yep, cost and made it more difficult to explain and to share. So we're having to go back and kind of redo that. And so that as well as where you asked about having the Medigap and different things. So there are folks that when they come on board, and I can say some a couple of recent situations that we've had. There are people that we have to go through recertification. Boy, I'm right on.
Next slide.
Hospice care, when it's provided, when a patient elects hospice care under the Medicare benefit, they are electing benefit periods. And there's 2 90-day benefit periods followed by unlimited 60-day benefit periods. Years back, 20 years ago, it was 2 90 days, 2 60s, and a 30. And if you didn't die at the end of that 30-day benefit period, you either had to go off hospice or the hospice needed to keep you on and provide care for free. Somewhere along the way, and I tried to look to see when that happened, it changed, where they changed it from the 90-90, 60-30s to 90s with unlimited 60s. But with each one of those benefit periods, there are regulations, and once a patient comes, in order for a patient to come on service, the initial benefit period the patient needs to be certified by both their attending physician or a physician that has seen them and our hospice medical director based on those coverage guidelines that I just talked about. They need to deem them terminal. After that, if someone lives through the 90 days and they're going into any of the next benefit periods, it's up to the medical director only. It's the onus and the responsibility of the hospice medical director to recertify someone in that they're terminal. And this is where it gets a little bit glitchy with the attending physician, because the attending physician, oh yeah, you're still, but they may not have the extensive knowledge or the understanding of the criteria that people need to meet to be recertified. There's significant, that same criterion ongoing. We have to demonstrate both by the patient, and you can't lie, and it has to be documented, that they haven't improved and they've had a continual decline. So for folks that have dementia per se, or the Alzheimer's, they have to show, and it's usually about a 10% loss of weight in a 6-month time period. They need to be changing their functional status. They have to be not improved on that 7A score. They have to be at least where they were or declining. And so those are easier people to kind of see in their decline. But one of the situations that happens is that someone may come on, have one of those debilitating diseases. They will go into the hospital because they had pneumonia. They're very, very ill, and this happened just 2 times recently. In the Christmas time area, around the holidays, pneumonias, the flus were going on. People died from the flus. People would go in with debilitating disease. One person, these 2 in particular that I know of, one had heart disease, one had significant dementia. They both went in. They looked like they were dying. They wanted, they didn't want them in the hospital. They wanted to go home for comfort care. We brought them both on. Well, fast forward 6 months later, they're still alive and they've actually improved. They don't have their pneumonia ailing them anymore. They may not have improved greatly. Well, one person actually, she hardly needs her oxygen anymore. She can walk up and down stairs. She can do, a variety of things with her heart disease, and she's 94 years old. And just a little side note, it used to be we could factor age in if they were over 100 years old. We have patients on our program now that are 108 years old. We have probably 20 patients that are between 100 and 108 between Marion County, Marion Polk. We go a little bit into Lynn, Yamhill, in that area. So that's not, and they don't consider age a factor anymore for hospice care. Yeah. So that's where it gets glitchy, where people, if they don't recertify and they come back, they will go back to their Medicare A, and then if they've dropped their Medicare supplement or their Medigap and different things, they're kind of in a bind and have to redo again.
Okay, so I want to speak to that for our counselors. It's not published, but there is a special enrollment period available through the Regional Office of Medicare for people who are leaving hospice. I had a case study just earlier this year. This gentleman called 1-800-MEDICARE. He was misdiagnosed with pancreatic cancer. After further tests, after being on hospice for 2 months, he was told that he did not have a terminal illness. He still had a serious health issue with his pancreas, but he was leaving hospice and he did not have a prescription drug benefit. When he called 1-800-MEDICARE, the agent basically said, "Too bad, so sad." And then somehow he got a hold of the state office number, and I remembered in the back of my mind that there is a way for someone to get prescription drug coverage, which can be a standalone drug plan or an MAPD, when you are being discharged from hospice. So he was able to get into an MAPD that was going to be beneficial for him during his treatment plan. So for counselors, I just want to make you aware, it's not something that you or even I or Miranda at the state office can do, but if you have a situation like that and somebody has been taken off hospice, they do have a special enrollment. Write it up, fax it to us. We will facilitate getting that taken care of.
Is that information that I can share with our medical social workers?
You can.
Great.
Absolutely.
That's awesome.
Can send that to your social workers. We do have a question.
Mm-hmm.
Is the patient informed what their enrolling diagnoses are?
We would like to think that their physician has told them. You would be surprised. Not infrequently, we will get a referral on a patient, and we will call the patient and or the family, and they will answer the phone and say, "Hey, Dr. So-and-so referred you for hospice," and not everybody knows what hospice is, and we'd like to set up a time and say, "Oh, they sound good," and we will get out to the home and it will be the first time that they have heard that they have a life-threatening or terminal illness. So there's a couple of reasons for that. One is that just over time, more end-of-life care and goals discussions and palliative care were not traditional topics physicians had in their practice. It's not called training, but in learning to become a doctor. It just wasn't part of it. And some of the physicians, especially the older physicians, still have an interpretation of their oath that they take that they will do no harm. So there are some physicians that have more difficulty having those conversations with their patients, even long term, because they personally don't want to give them bad news, or they can't get themselves to give bad news, or they feel, we have heard this from doctors, they feel that they're giving up on their patient, and they can't do that. In essence, they're not giving up, so we're trying to encourage and provide the education, and now it's in schools and a lot of different things, and people are doing internships in palliative and hospice care. We're learning how to have those difficult conversations, how to go in. So what is your understanding about your condition, and having those conversations? What are you hoping for? What is your best outcome? And trying to learn to have those so that they can talk frankly with their patients. The other piece on that is that sometimes even when bad or horrific or sad or devastating information is given, some folks are in that emotional spot where they're not really able to hear it. They can't take it in. They've been told. We had a patient a couple weeks ago. I was talking to a physician that we were having difficulty, and he was calling because he was challenged with our nurse going out, that she kept talking about this, and he was really angry at her. And I said, so tell me more about this. Tell me more about this. And he, so I retold him, and that nurse was sitting in my office, and she goes, I told him that 5 times. And so we went back. So we ended up calling his physician, and because we were really wondering if he really did have the information or not. And she got on the phone. She goes, oh my gosh. She said, 18 months ago, I started this conversation with this gentleman, knowing that this was coming, and he's even lived way beyond what I thought he would. And so no, he has definitely had the information. It's documented in the notes. I'll send you the notes, but he was just not able to hear it. Yeah. He eventually did hear it, but taking that back, but we literally had to take that physician's written notes to him and show him that she documented it, that she had talked to him. So sometimes it's that way too. So yes and no on that. Most people do know. Most people know that they have some type of at least a chronic illness or debilitating illness. And oftentimes they will know, or their doctor has told them, or someone has talked to them along the way. Anymore, a lot of our hospital systems have navigators and palliative care programs, so they've have had more conversation and more goal setting. We've actually offered to our local physician, or the physicians in our service area, that if you need or want one of our staff to come and help you have the conversation or be there at one of the doctor's office visits before they come on, we do that as well. We also try to go to the doctor's office visits if they're already on service to help explain, to hear what they're being heard, so that we can reinforce it down the line as well. So, yeah, but it does get a little bit touchy. Yeah. So. Okay, so going back to the limited benefit periods, having to scrutinize folks, one of the hardest things to do is when someone is really debilitated and they have a long-term, low-functioning chronic illness. Those are the hardest folks to know, because they're not very living in society very well. They're oftentimes people that are either have had 24-hour care for several years, or they're in a care facility, and they're still they still are taking intake of some sort. They're still getting enough fluid to survive, but their condition isn't getting better, and they're not participating, but they're just at this flat kind of a plateau. Those are the hardest ones, where we have to go back and decide whether we can recertify or not. And sometimes we just can't. There's just not enough documentation, and the longer over a 6-month time period, longer that we go over 180 days, the more scrutiny there is on doing those recertifications. So what they also started to do a few years ago, for every 60-day benefit period, when a patient comes on board, so after 180 days, each 60 days, our physician or a nurse practitioner from hospice needs to go and put literally a face-to-face visit with that patient to help see and validate that they're still certifiable for care. And between the staff that has been taken care of in our documentation, we all come up and decide whether we can figure out if somebody is recertifiable or not. Oftentimes we refer to slam dunks, people that are obviously declining, they have obvious terminal diagnosis, they're really easy to tell, it's very easy to document. But there's those other folks that get into that plateau stage, and it's like, oh, they're on, and so we'll try to, we'll call this soft recert. Well, they've had a little bit, but not a lot to meet, but we'll soft because our gut is telling us that they're probably going to die. And sure enough, a couple weeks later, they start to have decline, and it's like, oh yeah, that was a good call. There's other people where we swear that they're doing good, they haven't changed, we take them off, and they unexpectedly die 2 weeks later. And so when someone is coming up for a recertification, we are supposed to be talking to the patient and family well in advance, and especially if we're not seeing those little pieces of decline, and now we're looking at that weekly on everybody. We're not just waiting 2 months, but we're really documenting and looking at that so that we can have the best predictors and get things reestablished. That being said on that, one of the other issues that came a little bit challenging in 2014, the DME companies, the durable medical equipment companies for oxygen, the beds, wheelchairs, those types of things, they now have more stringent regulations for them as well. So when someone goes off service, if they have, if we provided them a hospital bed, a wheelchair, bedside commode, oxygen, those patients need to have a face-to-face visit technically by their care provider who's going to be providing care going forward, and write the orders within that time period for them to continue to see if they qualify for care. Well, sometimes we only have a couple weeks window.
Because it's going to shift from Part A hospice covered to Part B DME
right.
covered.
Yes.
I see.
Yep. Yep. And our docs can write for a gap on a hospital bed or on a wheelchair or a walker, something like that, but they can't do it for oxygen.
Oh, interesting.
So now the DME company, if we have to discharge or if someone discharges urgently, like they revoke off service, they can't really provide it because they don't have the orders. We have to take it out because we're not providing care and we don't have the orders anymore. And so that's our most recent significant challenge. So we've been working with the local, our contract DME company, where they're giving us the information to send to the physicians, and they're also very prescriptive. They have to have certain words, certain documents, be written a certain way to really demonstrate that person's functional decline in that time period of why they're requiring it. And of course, for oxygen, a lot of people need to be, they want to have an oxygen saturation off oxygen at 88% or less for Medicare, and I think that's still standard. A lot of we don't often get oxygen as much for people on hospice care as we used to because it just doesn't help. There's other things that we can do, but for people that are on oxygen that have COPD or long-term respiratory diseases, they will usually qualify, but there's some folks that have it where they're off oxygen, they're at 92, 94%, and it's been more of a psychological help. Those are the people that are really challenged in getting their oxygen covered and are not happy when they have to be discharged because those things go away. So that's just another piece there. The Part D plan, the medication coverage, this is probably the biggest stickler that comes up within hospice care, not the biggest, but a pretty significant concern. When a patient comes on to hospice care, they may have just a few medications because they're so end stage, all their other things haven't been working. They're literally only having the medicines that we are treating the most frequent symptoms. We oftentimes will have, someone will come on a pain medication. They may have been on their, the hydrocodone or the oxycodone or, and even morphine already. They'll be on oftentimes or not have a medication, but we'll try to have a medication for anxiety. The most common one is lorazepam. We also will have medications to help for bowel care and for fever and for nausea and vomiting, and sometimes for sleep. So those are 4 or 5 symptoms that usually we're working with most folks on. There's other people that have had maybe a brain tumor or different conditions that have seizures. Well, they'll come on seizure medications and things like that. Things that you can really know that are providing symptom management for the end-stage illness and are still effective. The other ones, but there's a lot of folks that will come on and they'll have anywhere from 25 to 30 medications on board. They may have had 4 or 5 different physicians that they have seen, and different, they may have a cardiologist, they may have an infectious disease person because they happen to have rheumatoid arthritis. They happen to have cancer, so they have an oncologist. They had somebody else, they had a radiologist, and all these, and you would think that the physicians would talk to one another and not overprescribe or underprescribe, but work in coordination, a lot of times not. So one of the things that we do is look to see if those medications are still indicated when someone now is at end of life. Most medications are given at a time period that they're supposed to help to maintain to be either curative or really affect symptoms management for long-term wellness, not for end-of-life care. And as I said earlier, there's many medicines that come on board and they actually can do more harm than good because their vital organs aren't working anymore. Their liver is not metabolizing, their kidneys aren't filtering, their brain isn't taking in things the same way. Some of the most common medicines that become controversial are in the area of the Alzheimer's and dementia patients where they're on Aricept and Namenda. And for heart patients, when they're still on their Coumadin or warfarin, their anticoagulation therapy, or when they're on high cholesterol medications or the statins and the Plavixes. And our television commercials have not helped us. The Eliquises that are out there and the Celebrex and all the different things that are available for folks, they're good drugs when they're indicated for prevention of systems and maintaining systems. But when someone has already gotten to the point where they're terminally ill, those medicines aren't really effective anymore. And especially like the Namenda and the Aricept, those are meant to stop the progression of disease and prevent things from going and help the symptoms. If someone is declining in spite of them, they're not working anymore. The time that we will recommend and say that we would not be covering those long term because they're considered preventative now or life prolonging. And so they would not be part of the hospice plan of care. They're still related to the terminal illness, but they're not part of the hospice plan of care. So those medicines we would say that we would not support. Sometimes the patients say, oh, that's okay, I'll continue to get them because I'll get them under my Part D. Can't do that. So if they really are related to the terminal or related conditions for decline, Medicare D, hospice has to pay for all of the medications that if they're part of the hospice plan of care, they have to be procured and paid for by the hospice. If they're related to the terminal but not part of the hospice plan of care because they're either futile or causing more harm, we can't agree to pay for them or to get them. So it would become the patient's responsibility. If they want to continue to take them, they'd have to pay out of pocket for them. And that is a hard pill to swallow, no pun intended. It just is. People don't want to. And those medications, if you haven't checked medications, I think you probably already know, some of these medications, one tablet could be $10 to $20 per tablet. They're often anywhere from $200 to $500 for a week or 2 weeks worth of medications. Some aren't, and they keep changing based on the pharmaceutical companies and whether they go off patent or not, and it's a changing environment. So those are hard. The cholesterol medicines, the clot medicines, those types of things for people that have high cholesterol. By the time you are end stage with cardiac disease, no amount of cholesterol medication is going to stop you from having a heart attack or having a stroke or things at that nature. They may think it is, but what actually is more preventative and helpful at that time is your baby aspirin. So having someone stay on the baby aspirin, that has been found to be more beneficial than most of the other medications, including even the Coumadin or warfarin therapies. The warfarin, the Eliquis, a couple of the heparin, a couple of the different medications. If a person has an active clot, if they have an active blood clot in their lung or in their leg, and we're treating it, we will continue to provide that medication. But if it's for preventative purposes, people that have atrial fibrillation, which is a common condition that of a heart rhythm issue that's not fatal per se, it can throw clots. People are on Coumadin because of their atrial fib. At some point in time, again, it's more beneficial at this point in time because there's less risk and less harm taking an aspirin. When people get to end of life, they are at risk for polypharmacy contraindications and side effects, and they're at a higher risk for fall. More people end up having a head injury and falling and having a bleed in their head when they've been still on their Coumadin because they fall, they have an injury and they bleed due to the Coumadin versus the injury from the fall. So if they're at high risk, we will encourage them coming off or to pay out of pocket or switch to aspirin. So those are some of the hard, challenging conversations that come up, but we are on admission. We're looking at that list, and we have the conference on our patients every 2 weeks. We're looking at that list. Our physician and the clinicians are working with the family on each and every one of those, and sometimes it's a stepping stone. Everything doesn't come off all at one time, but you slowly go to the point where you're providing just true comfort measures or comfort medications only. And I just had a train of thought that I didn't want to forget. I'll come back to it. It'll come back. So the Part D, so patients, though, that do have unrelated conditions. So the common one, people will come on, they may have cancer, but they also have a thyroid condition. They've been on levothyroxine or Synthroid for some time. They can continue to have their Synthroid because it's not related to their terminal condition. So their Synthroid can be paid that can go through Part D. If someone has a lung cancer and their diabetes is not really related into that lung cancer, their insulin and all those things can be paid for by Part D, and it's not part of the terminal illness. So there are several like that, and it's just kind of going through. The ones that are more glitchy are the ones that are still kind of related to a condition but not effective, is where we get into more challenge. And then people can pay privately. If people decide to go to their local pharmacy, so most of the hospices have their contracted pharmacies and their contracted services that they have contracts with, so we can get better pricing so that we can manage that care more so, and that we can have freedom to do what we need to do for our patients. There is a process. So for us, I'll use my hospice as an example. We have a buying group that's a hospice-specific buying group that's called Delta Care RX. When our patients within this group can go to any local pharmacy, and we are contracted with Sublimity Pharmacy for our delivery service for the meds that come out of there for our comfort kits. But any pharmacy that has a contract with Delta Care ahead of time can go and use that pharmacy to get hospice medications. There is a process. They need to be given a bin number and in a certain way to process them so that they adjudicate through. And so the pharmacy bills the buying group. The buying group bills us. We pay the buying group. The buying group pays the pharmacy. So sometimes we have some pharmacies that don't quite get people set up in the system right, or are from the get-go, or they don't know their hospice, or they'll go through in a patient family. We usually will order the medications and get them processed and things for people and delivered oftentimes. But sometimes on some of these ones that are either Part D or on private pay, the patient or the family may go to get those medications and not letting them know that they're on hospice. So they start putting them through the system, and even some medications that should not go to Part D, that are hospice medications or that are private pay, will go through and they'll process. but I will guarantee you they will get spit out later on, and there's an audit going on and fraud audit going on, so that they went back 2 to 3 years in the last couple of years to recoup all those monies, and we had to repay the pharmacies and the whole 9 yards because they weren't processed right. And so when the family does it, it's hard, because if those were private pay, when we get that back, we still can't pay for them, even if we want to be nice. we can't, because it's a fraud. It's considered incentivizing, and so that some of those payments will come back onto the family member or back to the estate even after the patient has died. So we really try to do our due diligence up front to make sure that things are being processed the right way. But they will trip up later on, and then it's causing a lot of rework to go back.
So for counselors, I guess that the take-home message I just heard is make sure if you have somebody who is looking at possibly going on hospice, that they are well informed of how to purchase whatever medications they will be continuing, so that they are determined to be a hospice benefit or not a hospice benefit, and going to the correct pharmacy and or providing the correct billing. Is that what I'm hearing? Okay.
Absolutely.
Okay.
So the clinical pharmacy services and the medication, adjudicating the medications. The other piece that for the hospices that I want to point out is that we are contracted. We need to be contracted with anybody who we render services from and exchange money with. So the other part of the benefit, depending upon the hospice that you are choosing and electing, and first and foremost, each Medicare entitled recipient is entitled to choose any Medicare certified hospice. That is one of the issues that there are some entities that will automatically refer to certain hospices that they have developed relationships, and that's fine if the patient or the family is elected, if that's fine, or if they have an exclusive contract. For instance, Willamette Valley Hospice has a contract with Kaiser Permanente here in Salem. We have a preferred provider, an exclusive for their Kaiser benefit members. So if someone goes on Kaiser, someone that has Kaiser insurance needs hospice and they are not Medicare, they will automatically be referred to in our county. There's Portland up there. The folks from the Portland area will go to the Kaiser that's based in Portland, but they will come to us. But a Medicare recipient, we will still get those referrals, but if a Kaiser Medicare recipient chooses to want Signature Hospice or one of the other 11 hospices in the area, they can actually choose to have that because they're entitled to it under the Medicare benefit. What was happening is that there were some people who were not giving some of the care facilities and some of the physicians and some of different people were not giving patients choice or not letting them have a choice. And that has gotten into to be a little bit of a stickler where people that are in adult foster care homes, in assisted living areas, there are some assisted living areas that have their corporate structure has their own hospice, so they automatically refer to their own. And if someone wants a different hospice, they'll say that they can't have it. Technically, they're entitled to having the other hospice come in, and most will call the other hospice and have multiple hospices in their facility. There are a select few that say, no, well, you can elect the other hospice, but you can't stay a resident here. And
Wow.
So it's a little bit of a slippery slope there, but that does come up on occasion when people are electing hospice services, but for the most part, everybody's 90% playing by the rules, and but everybody needs to have they are entitled to choose the hospice Medicare certified. Also, during care, a patient can choose to change hospices. If they don't like a hospice, they can transfer to another hospice during a benefit. One time during a benefit period, they can transfer. If they went from a hospice and then want to go to another hospice, they could still do that, but they'd have to revoke services and be discharged and readmit to the other hospice. And it's more technical on the back end than anything. Patients that elect the hospice Medicare benefit can only be discharged from hospice services in 3 ways. One is by what I have talked about, the non-recertification process. They can come off by non-recertification. The other one is if they go out of the service area. There are sometimes patients will go on a final trip, they'll go on a cruise, they'll be in international waters. We can't continue to provide hospice care when we cannot contact them or they're in international waters. But if they travel out of state and they're kind of local in one area, we have traveling contracts that we can still provide hospice services where they are and then have them come back when they come on board. But if they literally go out of the service area and don't let us know, or if they're going out and we can't provide service, we have to discharge them that way. Actually, there's 4 ways of discharge. The third one is a patient can, or a family can, representative can revoke hospice services. That is when the patient or the family member or the healthcare rep is choosing to go off hospice. They may want to be choosing for aggressive care. They may not like us. They may say it's not time, but it has to be their choice. A hospice can't make someone revoke services. And where that comes up, if a patient, for the most part, I was starting to say about contracted services, we have to be contracted. There's 4 levels of care in hospice. There is the routine level of care, there is a respite level of care, there's continual crisis care, and there's general inpatient care. 95 to 98% of all of our patients are on routine level of care, meaning they get daily services, they're in their home, it's a routine level of care. There is a provision that a patient can go into a skilled care facility or into a respite facility that we have a contract with for up to 5 days at a time for family, to give the caregiver a break. It's not supposed to be a bridge to a long-term placement in a nursing home. It's supposed to be sometimes it ends up being because the family just falls apart, or they realize they're so beyond their means that they're in respite, and then it's like they decide they really need long-term care. But there's a 5-day respite, and the 5-day respite can happen as often now. It used to be only once a benefit period. Now it can happen as often as the team feels it's necessary, but it can only be 5 days consecutive, then there needs to be a break in between. So there are some times where we had a situation where a family member had 2 family members who were, there was somebody that was terminally ill in Hawaii, and they were the caregiver for the family member here. That person started, actually the person in Hawaii died, so the caregiver needed to go over to finalize business and take care of their, so she was going to be gone for a week to 10 days. We actually had that person that was here go into a 5-day respite. That particular person paid for the day in between, and then we continued another 5 days.
That's what happened to my sister-in-law.
Okay,
Yeah, same thing.
so that's, so that can happen. The continuous level of care, the crisis care, is where we actually go in the home where the patient's symptoms are so severe that we need a nurse or a physician there continually for over 8 hours in a 24-hour period, and with 50% of that care being provided by a nurse or a physician. And they're usually it's when their symptoms are out of control and they need somebody there, and we can bill for that continuously, and it's a higher rate of care. Those patients, it's usually for a short stint of care. If they're that bad, and we really, I would say the kind of rule of thumb is 98% of the time we can get patient symptoms under control in their home setting. We have enough avenues and venues and opportunities of using medications and different therapies in different ways, more so than what they do in a hospital system. They're more limited, we're not. Still within law, still within prescribing, all those things, but we have more freedom to be more liberal with things because someone is dying in stage. But if we can't get them in control, and people sometimes if they're really having delirium and confused and are combative and really unsafe, we'll try to manage them for a while, but if we can't get them, we might have them go into general inpatient, meaning that they can go into a hospital or a skilled unit. We only are contracted with hospitals to provide this level of care. Or if someone's in constant seizure activity and we can't get them comfortable, we may have them go in. It's rare that happens, but it's for uncontrolled symptoms. And there's very strict requirements to be able to provide general inpatient care. When I said earlier that most patients are provided care in their home, there are a few hospice facilities. There's one in Albany. There's one in Portland, Hopewell House and Albany's unit. They are inpatient facilities. People do go to those places for hospice care. Hopewell House is primarily for, but it's like it's like an inpatient care for, or it's a inpatient setting for hospice patients, kind of like a hospice ICU, so to speak. Very high level, aggressive symptom management care. They do have a couple of beds that they can take on respite now. I think when I was there, it was only general inpatient care. Albany does have, it's primarily general inpatient. They do some respite care, and I think they might have a room or two for residential care. But those buildings are few and far between, and there's one in Southwest Washington here. They usually only have 6 to maybe 20 patients max. Willamette Valley Hospice does have an adult foster care home on its property. We had a very philanthropic gentleman that donated on behalf of his father to us a few years ago, and actually built an adult foster care home that is on near our office. That is not an inpatient unit. It's not a respite unit. It literally is under the Oregon adult foster care rules. It's just that you have to be a hospice patient on our program to be there. It's when they don't have a place to live, or and there's certain criteria that you need to go there, or if caregiving is an issue. And people, it's usually when they're in they're very the 2 weeks to 2 months of life when they come into the adult foster care. So that's a little bit different. Okay. The contracts that we have, as I said, all of the, I was going to go back into the liability as far as discharges. When I was talking about revokes, there are 2 other, or for a patient to revoke, one of the situations that we can't do is patients, when they agree to come on to hospice services, are agreeing to a hospice plan of care, and they're developing that with us. So the goals, the treatments, the options that they have beneath there. And if someone is deciding to, for instance, it's usually not going back to the hospital. It doesn't mean that they can't, but we need to be involved in the loop. If they're going there because we really can't get their symptoms under control, or they're really in crisis and we can't get to them fast enough, we'll say, yeah, go in, we pay for the emergency room services, or they get admitted and we do it under general inpatient. But people that kind of panic and go, or somebody calls and, you know, they come, they go 911, they go in, if we can't validate that they should be there, the risk is on the hospice, and we end up having to pay for those, and sometimes those bills can be sky high. The GIP, when people go in and we're involved in the loop, we have contracted rates that we provide care, so that the patients that go in only get the care that they need for hospice care. They don't get the automatic EKG and the 10,000 million blood work and the whole workup and the whole 9 yards. They go in literally for their symptom or what they're needing help with, and it's more modified, and saves the patient from a lot of wear and tear as well. So a lot of it is the communication. The challenges that we have currently are late referrals. Because the program can go for 6 months and beyond, and it's really, if the quote is that the patient is deemed terminal with a life-threatening or a terminal illness that they may die from if the disease takes its normal course within 6 months. If the disease does not take its normal course, which most of these, a lot of times they don't, it's not the normal course, but they're continuing to decline, live, they can stay on, and we can provide care. That being said, currently our statistics, and I was going to put it in here in another slide, hospices are plagued. The average length of stay for hospice care in our state right now, I believe, is 56, or ours is 56 for length of stay days. 56 days. The mean is 21 days.
Yeah, I know it's not utilized
January,
very well.
yep.
Yeah.
In the month of March and April, 76% of our people came on. 70, I have to think, I was going to put the slide in here so I had but 76% of the people came on. 64% came on in 2 weeks or less. 18% died within 2 days or less. We oftentimes get same day. some physicians have gotten into a panic because of the prognostication, because they don't need to worry about that. That's on our end. We can worry about that. But yeah, the late referrals, the reason why it's helpful to have a referral earlier on, if you know, is because going back to that hope, being able to support that person with their quality of life, doing goals, finalizing business, and taking control. They can't control the fact that they may be dying, but they can maybe have more control over how they're going to live their life until they do die. And that's having it upstream, developing the relationship and the rapport. Right now, a lot of hospices are spinning because not all we're doing, but a lot is come into crisis care. There's also a change of dynamics in the environment and with people. And, when hospice care first started, it was pretty much, as I said, more elderly, different people. There's sometimes some caregiving issues. Now, with the changes in mental health care benefits and different things, many of our patients are coming with combination terminal illness and mental health issues, family members with mental health issues, lower social economic situations, really people being in crisis and strife, and people are also being more verbal and open about their abuse situations that they've had in the past and how that ties in, the veterans and veteran care. So it's significantly more complicated now than it was 20 years ago. So that's also the changing environment. So, okay, questions? Got a few minutes left. That was a lot of information, Barb, and we thank you so very much. The next slide, I think, has Barb's contact information. So if you are in the greater Salem area, she mentioned Lynn County a little bit and Yamhill County a little bit. Yep.
But certainly if you had just general questions, Barb is a great resource. When my mom was on hospice, Barb was at Legacy Hospice, and my mom and I decided to go through Legacy Hospice, and we're really grateful to have Barb as our friend and resource. And so anybody who has any questions, please raise your hand and we'll recognize you or unmute you.
If you'd like, I could unmute everybody. Would anyone like to be unmuted?
Go ahead. We don't have too many on the phone. All right, you're all unmuted. If you have any comments, questions. No? All right, well, we can end with the last really cute picture.
The one thing that I really want to say is that everyone that is in my hospice family, meaning my cohorts, the community of hospice workers, almost everybody I can honestly say has a passion and a calling and a vocation to do this work. And we all feel it is an absolute privilege to be able to serve people at this time in their lives. And if there's any question, and the other piece I do want to say, I alluded to it earlier, sometimes things do go belly up. If you hear that from patients or families, encourage them to call us. We like to hear goods. We hear goods a lot, but sometimes, the way that we can serve better, and it's by all of you also being those advocates and the liaisons in between to give us information and to answer and to help clarify and provide information as well.
Yes, we just got a question. This is a recorded webinar. It will be posted to our webinar training page at the SHIBA.oregon.gov website. So if you are interested in revisiting any of the things that Barb shared with us, that will be a help too.
I wanted to say that personally working with Willamette Valley Hospice 3 times last year, you guys are fantastic. We had music therapy with my mom. She loved it, and you guys are fantastic.
I'm glad that we could serve you.
Glad that you had a good experience.
You did too. It was very short.
Mm-hmm.
my uncle who has been battling for several years with lung cancer, and my aunt had been caring for him at home. He's one of those people who got a late referral. He probably should have been referred 6 months ahead of time. but one day he just was feeling off. They took him to the hospital, and the next thing you know, they're like, he has pneumonia, and he's not coming back from it. So hospice was called in, and he was there 24 hours before he passed. But it was Willamette Valley, and they were wonderful. I mean, absolutely wonderful. So I have to agree with them.
Okay.
Can you type out the address for me?
Okay, so SHIBA, SHIBA .Oregon, OREGON.gov, and on our training page, which is on the right column of the home page, under volunteer training, there is a webinar option.
Also, if you're a part of group site, if you log in, one of the buttons on the top of the banner says webinars, and it takes you directly to that page. And we have one last little picture.
You just got to smile.
So try to end on a
Yeah.
happy note. Yes, this is what
Yeah.
we live for, is our grandkids at this point. And to serve all of our clients, obviously.
I was going to say,
Yeah.
there's a lot to live for.
Yeah. Okay. All right, everybody, if you don't have any questions, we'll let you go. Thank you for participating. We really appreciate you taking the time out of your day to join us.
Oh. So we have an awesome thank you.
I worked for MVH, from 80 to 60, 83.
I'm delighted to hear how you have grown and continue to thrive.
Oh, wonderful.
Well, thank you everyone for attending, and have a wonderful day.